Before we get started, can we get a listing of who the commissioners are who are on the phone? Nobody's on the phone right now? That's quick. Good. Commissioners, included in your packets are copies of the minutes from 3 sets of commission meetings, which include the February commission meeting and 2 commission legislative meetings that took place by conference call. Approval of the minutes for each meeting will need a separate motion and vote. I have one grammatic change on page 4 of the minutes from the regular meeting. Are there any other comments or questions about the minutes from the February regular meeting? Seeing none, do I have a motion to approve them? Motion second. All in favor? Aye. Great. Moving next to the meetings from the February 15, 2019 public meeting of the Commission regarding legislation that took place by conference call. Do I have any comments or corrections to those minutes? Seeing none, do I have a motion to approve those? Motion second. All in favor? And the third, approval of the minutes from the February 21 public meeting. I'm sorry, the March 1 public meeting of the Commission regarding legislation that took place by teleconference. Do I have a motion? And a second? Yes. All in favor? Abstaining. Thank you. Agenda item 2 is the update of activities. Commissioners have received written updates from our centers. Commissioners, do you have any questions on the written updates that we have received? Seeing none, did the executive director or any of the center directors have any additional updates?
Thank you, Mr. Chairman. I have one introduction. As you all know, Diane Arnold retired at the end of December, and we have hired a new executive assistant. Her name is Dee Stevens. Dee comes to us from work at the Maryland Department of Health. She spent a number of years with the Medicaid administration, and prior to that, she was with our colleague, Mark Luckner, at the Community Health Services Commission. She also spent a number of years with the Office of the Attorney General. Welcome, Dee. So I also just wanted to add one point. Our update does contain a number of references to work groups that are underway. I'm not going to go through all of them today, but I encourage you to look at the update of activities. We will be quite busy over the next 4 to 6 months as we bring a number of those work groups to a conclusion with reports presented to you before the final reports are submitted to the General Assembly beginning in the fall of the year. I say that because you'll hear later on this afternoon that there are going to be additional work groups convened as a result of legislation that likely will pass this year. So these functions take up a good deal of time. The participation of stakeholders is very much appreciated, and they do oftentimes lead to policy changes in subsequent legislative sessions. The other note that I would point to, given our long-standing interest in quality and price transparency, is that in February, CMS updated its 5-star rating system for hospitals. Those results showed some improvements for Maryland hospitals over the previous years. I'd encourage you to look at that section of the update and visit the CMS website, Hospital Compare at Medicare.gov. We will be updating our own website shortly to align with the results that we report in common with the federal government. On that note, we're in the midst of a review of RFPs to recompete the quality performance site, and we hope to have results completed and a recommendation to the Board of Public Works later in April. That concludes my update, but I'm happy to answer any questions.
Thanks. Ben, I was looking at the Where the Cost initiative and the episodes of care, and it looks like we have either 7 or 8, depending on how you read this, going to the work group. I'd really appreciate if you, like, how long do we think it would be before we could add additional things to the website? And do we have like a plan laid out for how we get to a comprehensive website in terms of episodes of care? Because I think that's a really important initiative that's doing really
So
good stuff.
the next phase of this, I think that's a great suggestion, and I'll ask staff to present a plan, the plan that we have developed for expansion of the website. The next addition will be the Medicare data, which we hope to add in May. We have run into a number of questions, I think, on some of the results that we want to look at more carefully before we publish. To that end, we've hired Remedy Partners, which is actually the new firm started by Francois Debrun, that spun off after he left Alterum to review the episodes. I think that's going to be beneficial and provide additional confidence on the results. After those Medicare results are released, and we're going to pivot back to the private sector and expand those, but a more comprehensive presentation we'll reserve for April.
Other questions for Ben? Hearing none, we'll move on to agenda item number 3. Certificate of Need, Prince George's County General Hospice Review. The 4 applicants submitted Certificate of Need applications to provide hospice services in Prince George's County. They are Montgomery Hospice, Beata, Emeritus Hospice of the Greater Chesapeake, and the PD Home Health Care Agency. This is a comparative review. Commissioner O'Grady will deliver the recommended decision. Commissioner O'Grady, please begin.
Thank you very much. Before I begin with my proposed recommendation, I would like to recognize the staff who was here from these 4 organizations. If you don't mind standing and just letting people know who you are. From Emeritus, we have Janet Squires, Area VP for Clinical Hospice. Brittany McClennan, Area VP for Operations, and Martha Harding, Counsel. Thank you for coming. From Beata, we have Margaret Winthrop, Counsel. From Montgomery Hospice, we have Ann Mitchell, Montgomery Hospice President and CEO. We have Cornelia Strong, Montgomery Hospice VP for Strategic Development. Sue Lynn Schramm is consultant, as is Eric Crowder is counsel. Thank you. From PB Health, we have Jackie Bailey, CEO. We have Matthew Bailey, COO and CFO. We have Lena Woody, General Manager. We have Andrew Solberg, consultant. Howard Solins, attorney. And Jack Eller, attorney. Thank you very much. As the chair pointed out, this comparative review involves 4 applicants that seek a Certificate of Need approval to provide general hospice services in Prince George's County. On March 1st, I issued a recommended decision recommending the commission approve all 4 applications. 2 of the applicants, Emeritus and Montgomery Hospice, are existing hospice providers in the state of Maryland. Beata provides home health services in Maryland and provides hospice services in 4 other states. PD Health is a Maryland home health agency that seeks to establish a general hospice. Medicare.gov has rated each of these applicants as relatively high-quality provider. Prince George's County has one of the lowest hospice use rates in the state, 28%. This compares to 43% for the rest of the state and 48% nationally, so about half. Prince George's County, with a population of over 900,000, is the 2nd most populous jurisdiction in the state. The combination of a low hospice use and county's large population means that there is a significant opportunity for new hospice providers to increase hospice use. While there are no guarantees that adding new hospice providers in Prince George's County will increase hospice use, approval of these 4 applications will increase access for county residents to additional quality hospice services. My initial review showed that none of the applicants was fully in compliance with the charity care standard, as well as a few other requirements. Modifications were needed. For this reason, and with the agreement of all parties, I conducted a written project status conference. I advised each applicant of the changes required for their application to meet the standards for approval. Each applicant submitted a modified application that met the applicable standards for the hospice services chapter of the state health plan and general CON review criteria. In my judgment, all applicants are now ready for approval. In addition, I believe that adding these 4 hospice providers will help reach the Commission's goal of increasing hospice use rates in Prince George's County. I move that the Commission adopt my recommended decision to approve applications for Amedisys and Montgomery Hospice to expand their hospice services areas into Prince George's County, and approve the applications of Viata and PD Health to establish new Maryland general hospice programs in Prince George's County, with the following conditions. 1, prior to first use approval, each hospice provide documentation of its link with hospitals, nursing homes, home health agencies, assisted living providers, adult evaluation and review services, senior information and assistance programs, adult daycare programs, the Prince George's County Department of Social Services, and home health delivered meal programs that operate within Prince George's County. In addition, prior to first use approval, each hospice provide documentation of its system for providing respite care for the families and other caregivers of patients. Thank you very much for your time and consideration.
Thank you. Before we proceed to a motion, do I have any discussion, any questions, any concerns from any of the commissioners?
I guess just kind of a question I had, nothing that would kind of keep it, and so if it's outside the scope of this, I'm happy to withdraw it. But I noticed that there were, I think it's 5 other hospices outside the 3 that are providing the main that have really low usage rates. And so my question was, do we have an ability to sense that this is a lack of available services versus lack of demand? Because I noticed that I actually went back and looked at some data, and PG County has a pretty high African American population, and there's pretty substantial literature that the African American community is not as interested, or not as they're more interested in pursuing more aggressive measures, and that may be part of the issue, and the reasons for that are multifactorial. So I'm just wondering if there's a sense for if it really is lack of services as opposed to demand, and that's what that was. Just from moving forward, I'm just kind of curious.
Well, and I think that part of this is to think about kind of how you would do an outreach to a community that perhaps you're not traditionally reaching out to. Right.
Exactly.
And how do you do that? So might we still see, after kind of making sure that there is kind of good, proper access to these sort of services, might there still be something of a differential? In my judgment, I would be amazed if it was half the rate that we see in the rest of the state. So if I'm not saying that increased number of services, increased number of providers will be the be-all and end-all, but it is certainly a step in the right direction to start to reduce that disparity that we currently see.
I agree with that.
Yeah, it's sort of a shame that Commissioner Thomas is not here. I think he would probably
I was
have
hoping he would be there.
the
Actually.
greatest
I would
expertise
have loved
in
to heard
addressing
his
that
comments.
issue. But if the issue is one of choice, of active choice, of not using hospice, that's one thing. If the issue is one of access or education, that's another. And I think all we can do, we can certainly pay attention to both those things, but we certainly have an obligation to do is to make sure that there is both access and education in
100%
place.
agree.
Hi, is there any concern with 4 new hospices coming in together at the same time that there'll be enough trained staff to take care of the patients and families?
That was part of the review to make sure, that things like nursing ratios, different things like that were done. That is part of the back and forth that went on with the applicants to make sure that those sort of concerns were, that this was going to be, a full presentation of access to full services, not a toe in the water that we hope, but, there's not really anything to back it up. So that was part of the going back and forth. And these 4 providers all, to their credit, were ready to step up and step into an area that does not have that much, as you pointed out, does not have a lot of hospice use, They clearly looked at it from their own point of view and their own business model and decided that this was an opportunity to actually be able to provide services to a currently unmet need. But certainly part of the review was to make sure that that those kind of services were legitimately and fully available. Yeah.
I think you touched on part of it, but in terms of the access, is there outreach for education? Because I think that's part of the dilemma of why there is such low use of hospice within the African American community. They're not trusting of hospice. So I think if there is planned outreach from the companies, that would help improve.
Yeah. Would anyone from the 4 applicants like to address that question?
Please
One.
step up to the microphone.
Yes, and identify yourself again for the.
Green is go.
There you go. Howard Tollins from the Baker Ober Health Group, and obviously our clients can speak for themselves, but I'm happy to answer that. It's no accident that the commission finds need in 2 jurisdictions, Baltimore City and Prince George's County. And I think Dr. Peterson touched on the issue, is trust and acceptance, particularly among the African American community. I can't speak for the other applicants, and we don't oppose them, and we think that, they're all, everybody deserves, to be approved. It is interesting. There's only one African American owned home health agency in the state of Maryland, 30-year history with the Baileys, and this will be the first African American owned hospice in the state of Maryland. And that doesn't mean that others can't be sensitive and reach out and employ the staff and need to do, but they do operate for over 30 years at high quality in Baltimore City. So in terms of their particular ability to be sensitive to the needs of the community, we think that in terms of the access and utilization, we think, again, there's no reason that everybody can't compete in the marketplace. But for PB Health, we think this is a signature approval by the commission in terms of who is not just providing the care, but who owns the model and delivery of care in this model. So PB Health is very grateful for that. Okay? Is that right? Okay. Thank you.
Yes. Did you want to add anything more? That's why you pay for such high quality attorneys, right?
Thank you. Are there other questions? Sure.
Working now. Just a question about Amedisys and there's some background that there were false Medicare claims, but just some understanding that that's in the past and the people involved in it are in the past.
That is beyond my area of expertise, so I think I'll ask staff, whoever, Sue Ellen or Kevin or whoever would like to address that. Or at least who is willing to address that, whether
Like
they
the
want.
Amedisys team to come up and address it?
Yeah.
Please.
Either way.
Please turn the microphone on and introduce yourself if you would, please.
Thank you. Again, Marta Harding, counsel for Amedisys, and I've got Janice Byers here and Brittany as well to help answer the question. As we disclosed in the application right up front, there was on the home health side of Amedisys company, there was a corporate integrity agreement that we entered into with Medicare several years ago. It's actually, I believe, going to be expiring in just another month because we have fully complied with it. It is and met all of the criteria. We entered into that without admitting that anything, in fact, had happened, but of course, out of convenience to try to just address the issue and move on. There have been a variety of things that were, in addition to maintaining its robust compliance program, the corporate integrity agreement required a variety of other additional protections to ensure that Amedisys continued to comply with the requirements, including an audit program, and I'm going to let Janet speak to that a little bit. We believe that we appreciated the reviewer's comment that notwithstanding that we have maintained a very high quality program in Maryland. We've served 4 counties already. we're serving high quality. There's not been any, this was on the home health side, it was not on the hospice side, and we believe that we have met the commission's criteria, and we appreciated the comment by Commissioner Brady that we continue to provide high quality care. So Dan, if you want to just speak briefly to the.
Sure. I'm Janet Squires. I'm the AVP of Clinical. We have the compliance team put together two types of audits, a clinical review of the claims on the side, and they also put together a clinical review of the documentation that is submitted. So it's a twofold compliance audit that is in place. We have a very low error rate. It's a financial error rate of 2.7%. That's been the highest, which is way below the expectations of the CIA agreement, and it will close in April of this year.
Thank you.
Thank you. Any other questions for Amedisys? Any other questions for Commissioner?
Staff then?
So, in the absence of Commissioner Thomas today, I wanted to just provide a brief summary of Dr. Thomas's efforts in Prince George's County before we opened up the county for new applicants, which was with his assistance as well as the county health officer. We convened a number of meetings with existing hospices in Prince George's County, talked about some of the challenges. The existing operators were generally enthusiastic about what they were doing. We allowed for some additional time, went back and reviewed any additional uptake on the part of patients in the Prince George's County. Didn't see anything that seemed significant. And then almost 2 years ago, perhaps a bit longer, we opened up the county for new applications, and the result is today. I would note that the Commission has not awarded new hospices for a number of years in any jurisdiction. The industry has been very reluctant and concerned about increases, but they've recently changed their perspective on this. I think recognizing the important role that hospice can play in the new total cost of care model, as well as recognizing that there is unmet need. I would say that the hospice CON is somewhat different than the way we approach other healthcare services in which we worry about induced demand. With hospice care, we think that concern is not so great, and in fact, look at utilization levels where in other types of services, if we have low levels of service, we might think that's appropriate. But with hospice care, the fact that there is less usage does suggest that other operators, perhaps with new strategies, and it's my hope that we do see some new approaches with these new additional entrants, and would in working with communities in Prince George's, see some increased use of hospice care.
Do I have a second?
We have a motion and a second. Any additional discussions regarding the motion on the table? Hearing none, all in favor?
Aye.
All opposed? The ayes have it. Congratulations. Next, I have on the agenda item number 4 in your materials, certificate of need for Adventist Rehabilitation Hospital of Maryland. In December 2015, the Commission issued a CON to Adventist Healthcare Washington Adventist Hospital to relocate and replace the hospital to White Oak, Maryland from Tacoma Park. At that time, Adventist Healthcare planned to maintain its rehabilitation hospital in Tacoma Park, Maryland. Over the 3 years, Adventist Healthcare has reconsidered that decision to maintain the rehabilitation hospital in Tacoma Park in light of the introduction of the total cost of care model and care delivery considerations. Today, the Commissioners will consider a CON application by Adventist Rehabilitation Hospital of Maryland and Adventist Healthcare to relocate the rehabilitation hospital's 42 acute rehabilitation beds to 2 floors that will be added to the new Washington Adventist Hospital under development in the White Oak area of Silver Spring. Kevin McDonald, Chief of Certificate of Need, will present the staff recommendation. Kevin.
Thank you, Mr. Chairman, and good afternoon, Commissioners. As Chairman Pollack mentioned, this is sort of the latest iteration in a project that has evolved since it was first approved in December of 2015. And I think much of that evolution has been enabled by an improving financial situation with Adventist. I think many of you were, not too many of you were on the commission when the Washington Adventist relocation was first approved, but many of you have been here in the last couple of years when the first couple of modifications took effect. One in 2017 added a central utility plant and a parking garage. The one in 2018 added 10 psychiatric beds to the new hospital and will relocate the remainder of those to the hospital in Shady Grove. This project would relocate 42 inpatient rehabilitation beds to that new hospital currently under construction by adding 2 floors. Under the original proposal, both the psychiatric unit and the rehab hospital were going to remain in the Tacoma Park facility, but I think as time has gone on and as regulations as far as freestanding psychiatric hospitals and the evaluation of Adventists that the expense that would be borne by the rehab hospital staying behind made this something that they wanted to bring forward. So this would relocate 42 beds at a cost of about $19.5 million. $14 million of that would come from economies realized in the existing project budget, with the remainder coming from the routine capital budget. In reviewing the proposal against our state health plan standards and CON criteria, staff found that the application conformed to the relevant standards in both the acute care and rehabilitation chapters of the state health plan, as well as the CLN criteria. Of particular note, the need for the beds is consistent with the projection in the state health plan for rehabilitation beds. Access would be improved by the availability of private rooms. The 42 beds in the new location would all be private rooms, whereas currently there are only 10 private rooms, which gives less flexibility because of the need for gender matching and particular conditions a patient might have. So it's effectively more capacity. As well, the physical location is just more accessible to the public and public transportation. Impact on other providers would be minimized. This is really just a replacement of existing capacity rather than additional capacity. Financial feasibility of the rehab hospital and Adventist healthcare overall would be enhanced by relocating it, as it would lower the rehabilitation hospital's cost for ancillary services and free it of the depreciation expense associated with ultimately being the only provider on that campus. As well as it does allow more flexibility in terms of the eventual reuse of that property. In summary, modernizing the hospital is needed. Operating the rehab hospital on the same campus as the replacement general hospital is the most cost-effective approach to meeting that need. The project is viable. Its impact will be positive. It can be implemented without a substantial increase in the spending levels already authorized at the new hospital. Therefore, the staff recommends approval of the project subject to a condition designed to bring the rehab hospital into conformance with Maryland hospital licensure regulations, and will match the data reporting and regulatory oversight of the hospital to its actual nature, the actual nature of its operation as two distinct facilities on separate campuses many miles apart. I think I neglected to say earlier that Adventist Rehabilitation Hospital currently operates in Rockville, 55 beds in Rockville, and the 42 in Tacoma Park. Right now, it's under one license, and the reporting is combined, which is a disadvantage in looking at utilization and projecting needs. Attending for Adventist today is Liz Katroba, an operations executive with Adventist Rehab, Martha Velez, finance executive with Adventist Rehab, Rob Jepson, vice president for Adventist Healthcare, Jeff Morgan, vice president for construction at Adventist Healthcare, Howard Solins, and Jack Eller, their counsel.
Thank you. Commissioners, any questions for staff or for representatives?
It may be beyond the scope, but what happens to the Tacoma Park facility?
The Tacoma Park facility? Yeah.
Well, it sounds like it's now, is it being repurposed or?
There will remain on that site a 24/7, 365 urgent care facility when the relocation occurs of the main hospital. Other than that, I don't know that it's been all buttoned up as far as what the eventual use of that facility will be, but this does enable a reuse that perhaps couldn't have happened without it.
Yeah, I think Robert Jepson with Adventist Healthcare, for the record. Mr. McDonald stated it accurately. There's a lag time for construction of approximately a year, so the rehab hospital will be operating in Tacoma Park. As a condition of the approval of the Washington Adventist relocation, we will be opening, upon relocation of the hospital, a 24/7 urgent care center. There is a condo physician building with a long-term ground lease that will stay, and then in terms of the longer term, a year, 2 years, 3 years from now, disposition, we're looking at various options and staying in touch with the local community about that. But we don't have a purchaser yet.
Yeah, thank you.
Other questions? Hearing none, do I have a motion to approve the application from Adventist? So moved. Second, Commissioner Hammersbach. Any other comments or considerations? Hearing none, all in favor?
Aye.
Aye. All opposed? None? Congratulations.
Thank you very much. On behalf of Adventist Healthcare, thank you. Also wish to acknowledge the good work of the staff, which held us accountable and did so in a collaborative way. So thank you to Mr. McDonald and his team, and thank you to the commission.
Thank you. They hold us accountable too. On to agenda item number 5, certificates of ongoing performance of cardiac surgery services. Eileen Fleck, Chief for Acute Care Policy and Planning, will present the staff report for 3 certificate of ongoing performance reviews for cardiac surgery programs. The certificate of ongoing performance application is a new process that is used to evaluate the performance of an established cardiac surgery or PCI program and determine whether a hospital should be allowed to continue to provide those services for a period specified by the Commission. Today will be the first time the Commission considers granting certificate of ongoing performance to any cardiac surgery program. The staff will present a report and recommendation for each of 3 programs. First, Adventist Healthcare Washington, Washington Adventist Hospital. Second, Peninsula Regional Medical Center, and 3, Western Maryland Regional Medical Center. We will consider each program in a separate action. After Eileen presents the staff report, commissioners may ask questions on that application. Eileen, please proceed with the Adventist report.
Thank you. Good afternoon, Mr. Chair and Commissioners. So Washington Adventist Hospital established its cardiac surgery program in 1962, and it's located in the Metropolitan Washington Health Planning Region, which includes 5 other cardiac surgery programs, although only 2 of those programs are located in Maryland. It is meeting all of the requirements for a certificate of ongoing performance, which I'll review now. First, each cardiac surgery program is required to participate in uniform data collection and reporting. This requirement is partially met through participation in the Society of Thoracic Surgeons Adult Cardiac Surgery Data Registry. This registry is one that is widely adopted nationally, and the purpose of participation in the registry is for hospitals to receive feedback on their performance and see how they're comparing to peers. The data is audited periodically by STS to validate the accuracy of the data. Hospitals submit data to the STS quarterly, and they also submit duplicate information to MHCC. Hospitals are also required to submit select information from the reports they get from STS regarding their performance twice a year. The hospital has been complying with the submission of this information. The next 2 standards addressed by Washington Adventist Hospital pertain to quality assurance activities. The CEO for the hospital is required to certify that the hospital complies with conducting and completing quality assurance activities that are specified in the chapter, and that the hospital has taken appropriate action to address any concerns identified through those processes. The information submitted by Washington Adventist Hospital, as well as other hospitals, is primarily confidential information. Therefore, the report focuses on describing the frequency of quality assurance meetings and the types of information reviewed. Also, in order to minimize the burden for hospitals, we ask that hospitals send the documentation that they possess already, instead of asking that they generate new documents or documents that fit a specific format from us. We concluded that Washington Adventist Hospital has provided sufficient information to document its quality assurance activities and the actions taken in response to any quality concerns identified. With respect to performance outcomes, a hospital is required to maintain an STS composite score for CABG cases that is 2 stars or higher. In the STS composite star rating system, a program may be awarded 1 star, 2 star, or 3 stars. 3 stars is the highest rating and indicates that a program has performed better than the national average compared to participants in the STS registry at a statistically significant level. A rating of 1 star indicates that the program has performed worse than the national average at a statistically significant level. The vast majority of programs receive a 2-star rating, indicating that they perform similar to the national average. The percentage of programs that are rated 1 star, 2 star, or 3 stars is not a fixed percentage. It can vary from year to year based on whether the program performs worse or better or similar to the national average. For calendar year 2017, only about 6% of programs received a 3-star rating, the composite rating for isolated CABG cases, that is, and less than 5% of programs received a 1-star rating. The composite star rating for isolated CABG has 4 components that are weighted differently for the composite score. One component is the operative mortality, which is the percentage of patients who did not die during the hospitalization for CABG surgery or within 30 days of the surgery if they were discharged. This component is weighted approximately 80%. A second component is the absence of major morbidity, which is defined to include reoperation, stroke, kidney failure, infection of the chest wound from surgery, or prolonged breathing support by a machine. The third component is use of at least 1 internal mammary artery for the bypass graft. And the fourth component is receipt of 4 specific perioperative medications that are believed to improve patient outcomes. So as shown in Table 1 of the report, Washington Adventist Hospital achieved 2 stars or higher for all 6 of the reporting periods shown. In fact, the hospital achieved 3 stars in 4 of those reporting periods. As noted in the staff report, isolated CABG is only one of multiple types of cardiac surgery that may be performed. However, it is one of the most common procedures performed and allows for a fair and consistent basis to look at hospitals and evaluate their overall performance. So Table 1 in the staff report indicates that between 66% and 76% of the hospital's cardiac surgery volume is covered by that performance metric. And the period that covers is January 2015 through June of 2018. The second performance standard addressed by the hospital pertains to risk-adjusted all-cause operative mortality rates. The specific standard in place for the time period covered by the hospital certificate of ongoing performance application is not applicable because we were not able to obtain a valid statewide average, which was the standard in place at the time. Instead, we provided information in the table that shows how the hospital performed on the revised standard, which was only adopted in January of this year. So the revised standard is a national benchmark rather than the statewide average. And in order to demonstrate compliance with the standard, a hospital's all-cause risk-adjusted operative mortality rate for isolated CABG cases has to be similar or better than the national average. Whether a hospital's performance is similar to the national average is indicated by the 95% confidence interval. When the hospital's confidence interval includes the national average, then its performance is considered similar to that national average, which was the case for Washington Adventist Hospital in each of the 6 reporting periods. So for each of those periods, the hospital would have met the current standard if that standard had been applicable. The staff report also contains additional information from the hospital on its performance that was not required, but that provides a fuller picture of its performance on cases other than isolated CABG. So the information comes from the STS reports with a composite star rating for aortic valve replacement cases, cases with combined aortic valve replacement and CABG, and cases with mitral valve repair and replacement. Because hospitals typically perform a much lower volume of those types of surgeries, the STS develops performance metrics for 3 years of data combined. And the data submitted by the hospital covers the period July 2014 through June of 2017. For each category, the hospital received either 2 or 3 stars, as shown in Table 3 of the staff report. With respect to volume, a cardiac surgery program is expected to maintain an annual volume of 200 or more cases. The hospital met that standard based on staff's review of the Health Services Cost Review Commission discharge abstract data for fiscal years 2015 through 2018. We counted those cases based on the definition of cardiac surgery in the regulations with the effective date of November 2015. Staff concludes that the hospital meets all of the requirements for a certificate of ongoing performance, and we recommend that the commission issue a certificate of ongoing performance for a 4-year period that permits the hospital to continue providing cardiac surgery services. That concludes my presentation, but I also want to mention that there are 2 representatives from Washington Adventist Hospital that are here today. Amy DeKosik, the Executive Director for Cardiac Surgery and Vascular Services, and then is Jennifer here today? Okay, so we just have one then. And so if you have any questions for Amy or for me, I'd be happy to answer them.
Commissioners, are there any questions? Seeing none, just want to congratulate Washington Adventist on the quality metrics that are listed in here. The 3-star rating for 4 out of 6 reporting periods is exceptional and should be noted. Do I have, hearing no questions? Any questions? None? Commissioner Sargent?
And maybe we'll get to it into the other reports, because I think on the other reports we had like 2 stars all the way across, and this one has some 3 and some 2. So is there a minimum standard you're evaluating all of these against? 2 stars?
They need to be at least 2 stars.
Stars and above, okay.
Right. So as I mentioned, like 90% of the programs, roughly, it will range from year to year, but a high percentage of programs do get 2 stars and are performing similarly.
So you have to be significantly above the national average. Significant defined as more than 2 standard deviations above the national average in order to be a 3-star.
I'm not sure, like they do have a way of looking at this that's very complicated. They have a whole formula that does involve looking at all of the data all together.
But it's generally 5 and 5, right? 5% of those are 3-star and 5% are 1-star.
It can vary. Sometimes it may be 10%, but yes, I mean, I think over time,
Relatively small.
it's small. Yes, it's going to be small.
The overwhelming majority of programs are at the 2-star level. So it says something to be 3 stars, 4 out of 6 reporting periods.
Right.
Okay. Other questions? Hearing none, I'll accept the motion to accept staff recommendation. Second. All in favor? Aye. Congratulations to Washington Adventist again. Thank you.
Thank you.
Eileen, please present the staff report for Western Maryland Regional Medical Center.
Yes, thank you. So I hope that people noticed there were a few minor corrections I need to make, and I tried to make sure that everyone got that report this morning, and the public copy should all be correct. So Western Maryland Regional Medical Center is an affiliate of Western Maryland Health System, which was established through a merger of Memorial Hospital and Medical Center of Cumberland and Sacred Heart Hospital. Western Maryland Regional Medical Center opened in 2010 as a consolidated replacement hospital for both of those other hospitals, and the cardiac surgery program at Western Maryland Regional Medical Center was first established at the Sacred Heart Hospital in 1999. The hospital is located in the Western Maryland Health Planning Region, which is the only hospital performing cardiac surgery for that planning region. The hospital meets all of the requirements for a certificate of ongoing performance except for the volume standard that sets a target of 200 cases annually. I'll next review the hospital's performance on those standards. Each cardiac surgery program is required to participate in uniform data collection and reporting, which is partially met through participating in the STS Adult Cardiac Surgery Registry and the submission of duplicate information to MHCC, as well as some supplemental information twice a year. The hospital has complied with those reporting requirements. With respect to the quality standards, the CEO of the hospital is required to certify that the hospital complies with conducting and completing quality assurance activities specified in the chapter, and that the hospital has taken appropriate action in response to any concerns identified. The hospital provided the requisite letter from its CEO, as well as meeting minutes and attendance lists for the quarterly quality review meetings that are held within the cardiac surgery department. The hospital also provided supplemental information on quality assurance activities that were not captured by its meeting minutes. Staff concluded that the hospital provided sufficient information to document its quality assurance activities and any actions taken in response to quality concerns identified. The hospital has also maintained an STS composite score rating of 2 stars or higher for isolated CABG cases in each of 6 reporting periods, as shown in Table 1 of the staff report. The hospital also received a 3-star rating in 1 period, calendar year 2015. The percentage of total volume of cardiac surgery for the hospital that is covered by the performance metric has ranged from 55 to 77%, but most often has been around 70% of the hospital's cardiac surgery volume. With respect to the risk-adjusted all-cause operative mortality rates, as I mentioned before, the specific standard for the time period covered by the hospital's application is not applicable, but we have presented information that is consistent with the new performance metric that we adopted in January of 2019. So for each of the 6 reporting periods shown in Table 2, the hospital's all-cause risk-adjusted operative mortality rate was lower than the national benchmark. There was even 0 mortality for 2 reporting periods. Although these results suggest better than average performance, the difference is not statistically significant based on the confidence intervals for each reporting period. So the hospital would have met the current standard if it had been applicable. With respect to volume, the target volume is 200 cases annually. That standard was recommended by our clinical advisory group that convened back in 2012, and the basis for its recommendation was literature supporting a threshold of 200 cases. Programs that drop below 200 cases may be more likely to have worse outcomes. However, the clinical advisory group also acknowledged that programs below 200 cases may also be very high quality programs, and it recommended that there also be a second lower threshold standard when a program drops below 100 cases for 2 consecutive years. At that point, we do what's called a focused review to look more closely at the quality of the program. And so the hospital is performing well above that standard. Based on staff's analysis of the discharge abstract data, the hospital is not meeting the target of 200 cases annually. It performed 166 cases in calendar year 2015, 150 cases in 2016, and 128 cases in calendar year 2017. Although the hospital's volume is below that 200 threshold and shows a declining trend, staff's review of the mortality and morbidity of the rates for the program suggests that it continues to provide high quality care. Staff concludes that the hospital meets all of the requirements for a certificate of ongoing performance, with the exception of the volume standard that sets that target of 200 cases annually. We recommend that the Commission issue a certificate of ongoing performance for a 3-year period that permits the hospital to continue providing cardiac surgery services. And that concludes my presentation. There are 2 representatives here for Western Maryland Regional Medical Center. Nancy Adams, Senior Vice President and Chief Operating Officer for Western Maryland Health System, and Dr. Gerald Goldstein, the Chief Medical Officer for the hospital. And so I'd be happy to answer any questions, or if you have questions for the representatives, that's fine.
Any questions for Eileen regarding the recommendation or the application from Western Maryland Regional Medical Center? Commissioner O'Connor.
Eileen, nice job.
Thank
Just
you.
one question about, there's only one surgeon during all these procedures?
There is one surgeon who primarily does all the procedures. There's a second surgeon who does some coverage when the other surgeon is on vacation or taking a weekend off or something.
So what's the criteria for an external review of his cases? There's no peer review.
Well, they don't have, I mean, they can't really have internal peer review. I would probably say that the hospital should answer the question in terms of external review and what their standards are.
If I see it says a mid-level, it's a, they're reviewed by a mid-level provider, the review of his cases.
Why don't we let the representatives from Western Maryland address that question? Please come to the microphone.
Thank you.
My understanding is the quality committee is made up of mid-level providers who are evaluating the surgeon.
Incorrect. That's not correct.
It says here. Page 3.
You point to where on page 3?
So I think the second paragraph under the quality heading where it says, in addition to the open heart surgery review, the hospital has quarterly open heart collaborative care meetings, and that group includes mid-level professionals. So there are two different types of meetings, but I'll.
In addition to that, there is, in the last 4 years, there's been an entity developed in the state of Maryland that all 10 open heart surgery programs participate in, and that is our quality agent in terms of peer review.
So it's built in external review?
Yes, yes, sir. By cardiac surgeons.
Great. Other questions? Thank you. Do I have a motion to approve a certificate of ongoing performance of the cardiac surgery program at Western Maryland Regional Medical Center? Motion, second, Commissioner Hammersclaw. All in favor? All opposed? None? Congratulations, you have a certificate of ongoing performance. I appreciate you driving all the way out in this weather.
It started out good, but it's just a little foggy.
So, unrelated to this, we are aware of the clinical collaboration agreement that Western Maryland has established with University of Pennsylvania Medical Center, University of Pittsburgh Medical Center. I think it's rather interesting, and staff are planning to schedule a meeting at a time that's convenient for Western Maryland to describe some of the features of that program. This is somewhat unique in that typically Maryland hospitals establish clinical collaborations with other Maryland hospitals outside the state, somewhat unusual. So we're excited to hear more about it moving forward.
Thank you. Arlene, would you please present the staff report for Peninsula Regional Medical Center?
Thank you. Peninsula Regional Medical Center established its cardiac surgery program in 1982. It's located in the Eastern Lower Shore Health Planning Region, and it's the only cardiac surgery program in that health planning region. The hospital is meeting all the requirements for a certificate of ongoing performance, as I'll explain next in more detail. Each cardiac surgery program is required to participate in uniform data collection and reporting, which is partially met through participation in the STS Adult Cardiac Surgery Data Registry and submission of duplicate information to staff. Hospitals are also required to submit select information from their STS reports twice a year. The hospital has complied with those requirements and meets the standards. With respect to quality standards, the CEO for the hospital is required to certify that the hospital complies with conducting and completing quality assurance activities and to demonstrate that it's taken appropriate action in response to concerns identified through its quality assurance process. The hospital has provided this letter and from its CEO, as well as meeting minutes and attendance from the quarterly meetings of its Cardiac Surgery Performance Improvement Committee. The hospital relies primarily on the quality indices provided through the STS quality reports, and it provided specific results for several measures for calendar years 2015 through 2017, both overall and for specific types of cardiac surgery cases. Staff concluded that the hospital provided sufficient information to document its quality assurance activities and the actions taken in response to any concerns identified. The hospital has maintained an STS composite score rating of 2 stars for isolated CABG cases for each of 6 reporting periods, as shown in Table 1 of the report. This performance is meeting the standard in MHC's regulations. The percentage of the total volume of cardiac surgery cases for the hospital that are covered by that performance measure ranged from 63% to 72%, but most often has been over 70% of the hospital's cardiac surgery volume. With respect to the risk-adjusted all-cause mortality rates, the specific standard in place at the time was not applicable. However, Table 2 has information on how the hospital performed relative to the new standard that became effective in January of this year. For each of the 6 reporting periods shown in Table 2, the hospital's all-cause risk-adjusted operative mortality rate was similar to the national benchmark. Although the hospital's risk-adjusted operative mortality rate was sometimes higher than the national average, the difference is not statistically significant based on the confidence intervals for each reporting period. The hospital would meet the current standard if it was applicable. The standard for volume is a target of 200 cases annually, and the hospital meets the standard. Staff's analysis of the HSCRC discharge abstract data shows that the hospital performed over 300 cases in fiscal years 2016, 2017, and 2018, which is well above the target of 200 cases annually. Because the hospital meets all of the requirements for a certificate of ongoing performance, we recommend that the Commission issue a certificate of ongoing performance for a 4-year period that permits Peninsula Regional Medical Center to continue providing cardiac surgery services. That concludes my presentation, and there are 2 representatives here for the hospital, Jeannie Ruff, the Executive Director for the hospital's Heart and Vascular Institute, and Chris Hall, who is Vice President for Strategy and Business Development. So I'd be happy to answer any questions, or the representatives are here too.
Are there any questions for staff or for Peninsula Regional Medical Center regarding their application? No questions? Burned out from the first 2. All right. Do I have a motion to approve staff recommendation to approve a certificate of ongoing performance of the cardiac surgery program at Peninsula Regional Medical Center? Mr. Hammersclaw, Mr. Boyle. Is there all in favor? All opposed? Hearing none. Congratulations. Thank you.
Thank you.
Very good. On to agenda item number 6. Yes, we will set a record. Okay. Megan, there's no pressure on you. The Maryland General Assembly is in the final 3 weeks of the 2019 session. Over the past several weeks, all 3 certificate of needs bills that conformed with the Commission's CON modernization report recommendations cleared their House of Origin and have crossed over to the opposite body. Staff is monitoring some other bills, including several that will direct MHCC to conduct studies or convene work groups. Megan Renfrew, Director of Government Relations and Special Projects, will review recent activities and describe legislative activities that lie ahead. Megan?
All right. Good afternoon. So as the chair mentioned, we have 18 calendar days left in the legislative session, so just over 2 weeks. And since we're near the end of the process, we're going to be covering a bit more content today than we have in prior meetings providing legislative updates. I want to start by noting that the legislative crossover date was Monday. This is a key deadline in the legislative session. Those bills that are voted out of their house of origination by that date have a much higher chance of becoming law than bills that did not get voted out by that date. All bills that did not cross over as of Monday have to go through Rules Committee to get approval to cross over to the other house, so that's an additional step in the process. Later in this presentation, I'll give updates on some bills, and I'll refer to crossover. So I just wanted to give you all a visual context for that aspect of the legislative process. Any questions? Okay. All right, so I'm going to start today with updates on bills that had hearings this week. We had 4 bills that we had submitted testimony on. The first was SB 901. This is the bill that would allow shock trauma access to on-call and standby funding through the trauma fund. This was favorably, we had supported that bill. It was favorably reported by committee and passed by the Senate. The House cross-filed bill has crossed into the Senate, been favorably reported by the Senate committee, and has second reader, so that will likely pass in the very near future. Senate Bill 1010, this asks us to do an assessment of services at the University of Maryland Medical Center in Chestertown. This was favorably reported out by the Senate Finance Committee and has passed second reader in the Senate, so it's moving forward. Senate Bill 1018, this is to create a rural healthcare delivery innovations pilot program with the Chestertown Hospital, related to the Chestertown Hospital. That also has passed out of committee and passed the Senate, so that will be moving over to the House. Senate Bill 1028, which is a rural health scholarship and grant program, was heard in committee earlier this week. We don't have a status update on that yet. So it was heard yesterday, so it's just too early to know. So I will keep you updated about that. Any questions about things moving this week? Okay. Moving on to bills with hearings. Next week, we only have one. And it's one we've already discussed, so this will actually be quite quick. This might help me. So the bill we have next week is Senate Bill 733. That has to do with registered cardiovascular invasive specialists. This is a level of provider that works under a doctor in a cardiac cath lab. This bill has already passed the Senate and crossed over to the House, and it will have a hearing before the House Health and Government Operations Committee on Tuesday. We've discussed it before, and we submitted a letter of information. Our letter focuses on there's 2 components to this bill. One has to do with providing the authority for this provider type and gives the Board of Physicians regulatory authority over them. We have not commented on that portion of the bill. That relates to some work the board has done, including a report that was posted before the legislative session on their website. The second part is that there's a study for us to do a review several years down the road of related to performance in cardiac cath labs. And so that's what we've commented on in our letter of information. Staff recommend at this point that we continue forward with that same letter of information, that there's no need to make any changes at this point. The study would require that we review, I already said that. None of the data that would be collected for the study is data that we collect, but it does, some of it is collected by the Department of Environment, so we could get it from them. Some of it would be collected by the Board of Physicians, so we'd be collecting it from them. And some of it MHA has volunteered to collect. So we'd be the gatherer and analysis component. Any questions about that? Okay. So the rest of my presentation is going to be just updates about some of the bills that are priorities for us and important to our work. So I did want to give you all the updates that the 3 CON bills that we've discussed in the past, have all crossed over from their house of origination, both the House and the Senate version. So that means we essentially have 6 horses still in the race. That's a good thing. And so we'll keep monitoring those closely. Somebody asked me at lunch about the psych bed component. So we had one bill that had some changes related to hospice, ICF for drug treatment, and to psych beds. The bill was amended in committee and the psych bed component has been dropped. So at this point, it's just a hospice and ICF bill moving forward. Yep. Yep. And then we've been monitoring the trauma fund bill also closely, but I've already talked about that. Any questions, more questions about bill status on these? Okay. Then next is the budget bills. We need the budget to do our work. And so I wanted to give you an update on how things are going with the budget and how that relates to us. The House version of the budget bill passed with amendments and has crossed over. It'll be the vehicle for the main component of the budget. That has a $34 million appropriation for MHCC, and that reflects an $8 million reduction in the ICN fund. This has to do with there not being legislative authority to spend that money, so they're taking the money away too, unless something changes with legislative authority there. They also added $100,000 of additional appropriation for operating grant funds for shock trauma. There also will be some reporting requirements that we will want to stay abreast of and have some loose involvement in. MIMS, which has authority over the EMS system in Maryland, will be required to submit a report on ER overcrowding in collaboration with HSCRC, and then also submit a report on the progress on reimbursement for EMS new model programs. So this would be essentially a continuation of the work group we've had this past year in collaboration with MHCC and HSCRC. And then finally, HSCRC will need to identify total cost of care goals and quality measures for Medicaid. And I think those are just high-level policy things that many of us would have an interest in. So I wanted to flag them for all of you. And then there's the Budget Reconciliation and Financing Act. You'll hear it referred to as the BRFA. The House bill has passed with amendments and crossed over. It has a $2 million transfer from the trauma fund to Medicaid for fiscal year 2020. The Senate bill had a committee hearing but has not otherwise moved. It does not have that transfer, so it keeps the money in the trauma fund. We expect the difference will be resolved in conference. Any questions about any of this? Okay. And so then there's a few other bills I wanted to mention. So one was the electronic prescriptions bill that we discussed and opposed. The future on that bill is a little unclear, although I think getting more doubtful every day. There was a fair amount of work happening over the weekend to try to come to some agreement on amendments, but it doesn't appear that the bill has moved since then, so that it doesn't appear to have moved out of committee in either house. We've also been tracking a bill related to school-based health centers. This is related to the work group. It's related in that it has to do with school-based health centers, not related in the sense that it has to do with telehealth. But we have a work group going on right now on telehealth for school-based health. And so it's something we've been keeping track of just to understand what's going on there. And that those bills have crossed over, so that seems to be moving forward. We've already discussed the cardiovascular invasive specialists And then we do have a work group going on right now related to infant mortality. And there are a number of bills going through the legislature related to particularly maternal mortality. It's a big year for that. But this is one particularly I wanted to flag because it has to do with health insurance access. This one has to do with a special enrollment period for pregnancy. And it has crossed over, the House bill crossed over, but the Senate bill has not. I'm also not sure, and didn't get to discuss with Ben, but whether this would be to a mandate study because it would be directing insurance to do something. But, so then finally, there are some bills. The session hasn't ended yet, so nothing has failed, but there are some bills where we can see it hasn't moved, and it didn't get a favorable report out of committee, so we can probably say it failed, and it's not going to move forward. So one of them is the bill related to reporting of financial gratuities and incentives that we talked about early in the session. That was duplicative of a federal program. That got an unfavorable report on both the House and Senate side. And then there were two bills that had to do with communications around facility closures and conversions, one by Representative Metzger and the other one by Representative Lasante. The Metzger bill got an unfavorable report from HGO and there was no cross-file, and the Lasante bill has not come out of committee. And then there was a bill related to C-sections, wanting to study C-section rates in the state, and that didn't not come out of committee, but we do expect that the sponsor will be working with the Maryland Patient Safety Center to continue some work they've already been doing with hospitals on C-section rates. And then finally, there was a bill that was seeking to establish comprehensive universal single-payer healthcare coverage and a healthcare cost control system. Obviously, that would have had implications for us, but that did not come out of committee in the House. So, questions? Yes.
Megan, one question about Senate Bill 1029.
Sure.
I didn't see it anywhere. Did it?
1029 or 1028?
29. Does this
Remind me what it is.
It had to do with a bill that would require some Eastern Shore facilities to establish a program to recruit physician assistants and nurse practitioners.
I had not put, we've been tracking it in our larger tracker. If you go to the commission website, you'll see that I post a tracker that's got 104 lines in it. So we're tracking it there, but no, I didn't put it on this list.
It's not listed. I mean, it just failed in committee, or
no,
it
doesn't mean anything. It just means I was trying to narrow down the number of things we talked about today, and I made a judgment. Yeah.
Yeah, I think those workforce bills were introduced by Senator Hershey and Senator Eckhart. The only problem is they were introduced late. They had hearings after the crossover date. The SB 1028, which I think has a lot of good elements in it, needs some additional work before it's ripe for adoption, I think. And the question is there enough time? Usually the last 2 weeks of the session are sprints to get things passed, not to do tune-ups on bills that need work. So I think the Eckhart Hershey bills and 1029 is sponsored by the two of them, probably falls into that category that they got introduced too late, but they do offer a lot of potential. Similarly, the School of Medicine at the University of Maryland Department of Family Medicine is also unrelated to legislation, working on a grant to HRSA to establish a rural residency program. We've talked about that a fair bit here in the commission over the last couple of years. The idea of establishing training programs in rural areas as opposed to having training programs in urban areas and sending residents out to urban for short periods of time hasn't been particularly effective, and we need to look at others. But we also have to recognize that you want to have at the very basic level sufficient experienced physicians out there to really run a program. So it seems like a good idea, but there are lots of challenges to actually putting those in place. But I particularly think 1028 we would say the commission would probably support it in concept, but there's lots of details that probably need to be worked out. Where it would actually be established in the Department of Education or the Department of Health is sort of a basic issue. It's my opinion that they're better deployed in the Department of Health than the Department of Education, but that's something the legislature would have to work out.
Other questions for Megan?
Megan, are you responsible for this very interesting letter from the American Enterprise Institute and the Brookings Institution? The Senator Lamar.
No.
It is legislative. It's a senator.
No.
Okay, I was just wondering if you're going to talk about it. It was interesting.
The letter is for information only at this point.
Well, to whoever put it here, thank you.
Legislation to follow. Next session.
Thank you all. And just a reminder, there is no Friday morning call tomorrow.
Thank you for that.
Yeah.
Very good. Okay. Agenda item number 7. Melanie Cavalier, Chief Innovative Care Delivery, and Alana Sutherland, Program Manager, will present on the Patient and Family Advisory Council, or PFAC Guide for Ambulatory Practices. CMS, other payers, and practice transformation experts consider PFAC's important components of practice transformation and a mechanism to bring the perspective of patients and families directly into the planning, delivery, and evaluation of care with the goal of improving care through policy and program changes. The PFAC Guide provides practices with information and resources to help establish, integrate, and expand the PFAC. Melanie.
Thank you. Good afternoon, Mr. Chair and Commissioners. So as Dr. Pollack mentioned today, Alana and I will be walking through the background, development, and the components for the Patient and Family Council Guide for Ambulatory Practices. So I'm going to begin by defining Patient and Family Advisory Council, also known as a PFAC. So a PFAC is a group of patients, family members, and practice staff that get together to work to improve patient-family engagement in the practice's strategic and operational efforts. So as he also mentioned, many of the federal and state programs have this as a programmatic requirement, and the National CPC Plus program, as well as the Maryland Primary Care Program, they're required to convene at least one PFAC meeting per year. So the guide has sections to create, integrate, and expand a PFAC. So in 2018, we competitively bid and selected the Institute for Patient and Family Centered Care to help in the development of the guide. Part of the development was engaging local Maryland practices in whether the guide was usable. So the very last page has a list of acknowledgments. So there were 25 practices that gave us feedback, 20 during the initial development, and 5 more towards the final development of the guide. So the guide itself is organized into 3 sections: a section for beginners, intermediate, and advanced practices. Each practice should select the selection that's most applicable to their needs and capacity. Many practices already have a PFAC, so they can move straight to section 2 or 3, depending on their areas of interest. So the practice should review and implement the strategies outlined in that section, and then utilize the additional resources to further inform their implementation. I'm now going to turn this over to Alana to work through some of the components in the guide.
Thank you. So I'll begin with section 1, which is intended for practices with little or no PFAC experience. This section of the guide will walk practices through foundational steps as they look to initiate or plan a PFAC, and it prepares practices for those partnerships with the patients and families. So section 1 includes the topics listed here, things such as recruiting patient and family advisors, or PFAs. And this section also focuses on ensuring that PFACs are well positioned to help a practice advance its transformation. So section 2 is about integrating PFACs into a practice. And so once a practice has established a PFAC, it would look to this section for guidance on how to make sure that the PFAC is functioning and that it's incorporating feedback from the PFAs into its improvement efforts. And the topics included in this section are listed on this slide and include things like evaluating a PFAC's effectiveness. And section 3 is intended for practices with more advanced PFACs. So these may have been around for several years, and they may have a need to address more in-depth quality and safety issues than a newer PFAC would have. And this section also includes strategies for involving PFACs in chronic care and other direct care improvement efforts. And the topics include things like implementing a shared decision-making process. So these are the key elements of the guide. These are included through each of the 3 sections that I just talked about, as well as in appendices, and I'll speak a little bit more about how each of these elements supports practices in preparing for those partnerships with patients and families. So first is each topic included in those 3 sections contains this element that we call what, why, and how. So in other words, the what provides a short description that helps explain the topic to the practice. The why describes the importance of the topic to the practice, and the how provides actionable steps that a practice can take as it looks to achieve certain objectives that it's identified related to that topic. The next section is frequently asked questions. So we provide these FAQs to support the practical considerations that were provided in the previous element and provide some discussion items and additional information for practices. An example of an FAQ in section 1 would be focused on introductory topics like what if some staff are resistant to working with PFAs. The FAQs in section 2 would be a bit more advanced and related to things like sustaining and advancing a PFAC with questions like how can I track a PFAC performance over time?
And the reason why a practice would want to track the PFAC performance over time is the staff and the patients and family members are putting a lot of obviously time and effort into doing this. And by reporting out at each of the meetings, then they would be able to show the progress that the PFAC is making and to show that it's worthwhile to continue these efforts.
Right, and then moving on to section 3, the FAQs are much more advanced with questions like how will goals and priorities that the PFAC addresses change over time. The next section provides short statements or tips that go above and beyond the information provided in the previous elements. And these give additional advice for providers, like the example here, which is taken from section 1 and includes some basic information for practices that have little or no experience with PFACs. Other examples from section 1 include things like asking existing PFAs to serve as mentors for new members. And the tips progress from section 1 to section 3 as they do in other elements for practices that have more and more experience with PFACs. So moving ahead to section 3, an example of a tip reads, develop a rating scale for the PFAC to use in evaluating existing educational material that supports PSMS or patient self-management support. And the final element within the main body of the guide is the quotes from providers and patients. And these serve as kind of words of encouragement or insight from providers and patients regarding the value of PFAC. And we include these because we found that integrating perspectives from peers can serve as a useful communications tool when we're communicating with providers. And so we've included examples throughout the guide from both local and national sources. And the example given here we feel is a really strong example of a patient perspective, and this is from a PFA at the Long Beach Memorial Medical Center and Miller Children's Hospital in California. And I'll pause there because Melanie wants to read another example from section 3.
So many of the PFACs were implemented in cancer centers as well as hospitals. So one I'm going to read is from Memorial Sloan Kettering Cancer Center, and this is from one of their providers. It means so much to be a member of patients, caregivers, and coworkers who are sounding boards, champions, devil's advocates, and coaches, all working together to push the envelope of what it means to provide exceptional care to our patients. Right. So again, they're really speaking to the value coming from the voices of people that are involved in the PFAC. So moving on to the appendices, I'll walk through each of the elements included there, and we'll begin with Appendix A, which includes 4 printable forms. And these are meant to just provide templates for practices that are implementing PFAC, and they include a PFA application, a PFAC charter template, a confidentiality form, and a template for meeting agendas and minutes. In Appendix B, we provide a link or a list of links to external resources. These are meant to really reduce the burden for users of the guide who might be looking for additional information in one cohesive place. And you'll see that the example given in the screenshot here includes resources such as the Leadership Self-Reflection Questions from the Patient-Centered Primary Care Collaborative, or PCPCC, as well as AHRQ's presentation titled Readiness to Partner with Patient and Family Advisors. The next element is the glossary, which just establishes a common terminology for users of the guide. The glossary is an excerpt from a document titled Key Steps for Creating PFACs and CPC Practices, and this is used with permission from the National Partnership for Women and Families. And so lastly, the final element included in the appendices is a list of healthcare acronyms, and again, this is just meant to kind of level set the vocabulary used within the guide. So that sums up the content, and I'll turn it back over to Melanie. Thank you, Alana. So for the next steps, we plan to post the guide to the MHCC website. We also then hope to do outreach and education, including partnering with the MDPCP to work with the practice to support that programmatic requirement to implement a PFAC, working with medical societies and payers to promote its use, and then also presenting at various local and national meetings that we attend. So at this time, I want to thank you for your attention and invite you to ask any questions that you may have.
Hi, this is great. Good work. I'm curious, do practices, in the introduction, it kind of indicated they're encouraged practices to establish them, and then it says Maryland Primary Care Program requires convening. And are practices, do they have to do it, or is this a choice?
So some of the value-based programs, it's an encouragement, such as the PTN program, so they can get points for convening one. The Maryland Primary Care Program and the National CPC Plus, it's an actual care delivery requirement that they must do. They have to have at least 1 year. So it depends on the program of whether it's encouraged or required.
And if it is required, is there any way that there's some oversight whether it's real and effective or not?
So I'm not quite sure how to answer that, to be honest. Is there oversight? They're attesting to whether they had one. I don't believe there is an actual audit by CMS as to whether it was a meaningful meeting. I do think that they're, they have to report out on what the results of that meeting are, and they are expected over time to have additional results.
And attestation is required, and subsequent investigation were to show that it didn't exist, that would affect the conditions of future participation with CMS.
Yeah, absolutely. That'd be considered, yeah.
Commissioner O'Connor?
Hi. I assume this PFAC is part of a primary care practice. Where do specialty practices fit in with this?
Okay, so actually PFACs really begin in hospitals. So they're very common in hospital settings, but they're also used by specialty practices. You'll notice that there's a lot from cancer centers especially, but many specialty practices implement them as well. So it's anyone who wants feedback from patients on how they're delivering care. Anne Arundel Medical Center, Johns Hopkins, most of the local systems have PFACs within their ambulatory practices as well as the hospital system itself.
But just to be clear, the only the requirements to have PFAC are currently limited to the primary care program. I don't think the ACOs operating in the state operate under a similar requirement, but tell me. No, I don't think so. So good idea, but as far as we know, the Maryland Primary Care Program and the National CPC Plus program, of which our program is an offshoot, are the ones that got us thinking about this based on our longstanding work with primary care practices who work oftentimes, how do we do this, especially the unaffiliated practices.
So this is probably a dumb question, but don't worry, everyone else is used to my asking dumb questions. Reading through the report, this is my first foray into what PFACs do. Is it purely to advise the practice, or is there a role in advising patients and families? Is it one way, I guess, information going up, or do they have more than one role?
So I think that they definitely can weigh into any of the materials that are going back out and advising patients. So you'll see in Section 3, there's a lot about the chronic care management, about the patient self-support. So the way a lot of practices employ them is when you're going to put up patient education materials or give out patient materials, they have this council review them to make sure that other patients understand it. So I guess you could say that it's going back out as well. I don't know if that really answers your question.
But they aren't advising patients with respect to any particular case. That's more advising the practice on how to communicate with patients.
So some of them use them in different ways. They could use them in that way if it was de-identified. They do all have to have HIPAA training. That's advised for them to have HIPAA training. They can discuss cases in under that, but that would be up to the practice on whether they wanted to get into the individual case and how to deal with the individual case.
This seems time consuming. Is there a CPT code for this interaction?
Very, very. The world is changing.
We're not paying for you to talk to each other, guys.
Are there any other questions you can answer this time?
Thank you very much. Thank you very much. Outstanding report. Ben, would you like to share the upcoming activities for the April public meeting?
So first off, I want to recognize the work of Commissioner O'Grady over this long period. I noted that we hadn't approved a hospice application for a long period of time. It's, I think, commendable for his diligence that he sort of broke the ice on this, and over the next several months, another one's going to hopefully come forward. It also, I think, signals some change of perspective on the part of the industry that they now recognize the importance of not holding to the fast to their own jurisdictions, and that they're willing to move into other areas where there's a need. They also supported the CON bill that allows existing hospices to expand their inpatient capacity, which I think is also a good note. So thank you, Dr. O'Grady.
Can I follow up on that with you? It was clear for some of you weren't here when we got the presentation maybe a year and a half ago, 2 years, where it really did show the great, and I just mean statistically, disparity, disproportion maybe is a better way to think of it, that the United States is now up to close to half, hospice rate, which is certainly very important in terms of end of care, both treatment and cost, obviously. But we still have some pockets. I think we should all celebrate that this was sort of an ugly pocket of underserved that hopefully we've taken the right steps to fix that. But there's still at least one other in the state, in the western counties, that are again in this sort of half the national average, half the state average sort of thing. So I would encourage the commission to double down our efforts, the same kind of effort that we made to make sure that the situation was addressed in BG. don't think there's anything about the culture of the Appalachian communities that would make them, reticent in any way. I think this is, again, an access and ability to get services. And there may be other challenges. I have a hunch it's going to be long distance, rural, kind of by standard set of rural challenges. But I would strongly encourage my colleagues to not stop here and to continue to go a little farther and take a look at this last kind of, again, big area of lack of access, underserved. Thank you.
I wouldn't jump to the conclusion that there are no cultural issues in the Appalachian community that are limiting access. That might very well be true. And,
keep an open mind.
Again, it's an issue of providing access and education. And if people decide for cultural reasons or cognitive reasons or any reason that they don't want to have access to those
things,
in the context of being informed, that's
well, we're not going to push it.
That's
on
freedom.
Anybody.
That's
right. That's
your
choice.
right in this country.
Right. That is a choice. When we see one county that's at national average or above, and then the county right next to it is half the national average,
strongly suggests a healthcare disparity that's related to something that could be and should be addressed.
Great.
Thank you for all your work in that area.
So yes, continuing on, and to Commissioner Sargent's point, the letter to the Senator Alexander and the ranking member from a set of economists from Brookings and American Enterprise Institute. I thought it was useful to share for two reasons. One, a collaboration of what would generally be considered liberal, moderate, and conservative economists could agree on some consensus recommendations that they sent to the Senate. I would also wanted to point out to you in that document were two that have direct bearing on us. One focuses on economists' long-standing position, really across the spectrum, on the importance of CON reform, and they actually put down some stakes in terms of what the federal government could actually do to incent states to eliminate CON. And secondly, I think this is noteworthy because it's sort of in the weeds, a note that the federal government should move proactively to figure out how the Department of Labor could change the ERISA statute, the statute that enables large employers to self-insure, but also gives them some reason not to submit data to all payer claim databases, of which Maryland has one, and Ken Mahi and others have been working on. So it's very, I think, very pointed on our work. I'd also note that one of the signatories to that is one of your fellow commissioners across the way, Joe Antos, who serves on the HSCRC. Moving to the commission meeting next month, I've taken Commissioner Sargent's recommendation. We'll have an update on where the cost is going. We will also have some additional certificates of ongoing performance scheduled. Eileen will be back in front of you with, I think, at least 3, perhaps more next month. We'll have a CON and an exemption from CON application before you in all likelihood. And we'll have the action on, finally, I think we will have the Maryland Primary Care Advisory Council membership forms, and we'll ask you to approve that. The Healthcare Commission is supporting the Secretary in convening this advisory council that would advise the program on changes to the program moving forward. It's a somewhat of a thankless job, I'm realizing, but one that keeps us involved with the MDPCP program in a meaningful way. Another note on just shortly before the April meeting, we expect that the regulations on COMAR 102420, the nursing home regs, will be published on April 12th. Those regulations were approved at last month's meeting. They will be published. There will be a day comment period, which would mean these regulations would come back to the commission in time for the June meeting. I think we had committed to you last month that they would come back in May. Just because of the publication dates, we can't quite meet that deadline. And we will also, I think, consistent with one of the discussions today, convene the psychiatric state health plan work group. You saw a white paper last month. You'll see the work group's beginning its work, and we'd hope to have proposed regs to you later in the summer on that. That was the major stalling point raised by Shepherd Pratt and why they got approval in the legislature to strike the provision in the bill to allow psychiatric hospitals and general community hospitals with psych units to expand without CON. They contended that the state health plan had not been updated. Megan and I argued that typically the way this works is that broad statutory changes are made, and then they are refined through regulations, which would be appropriate with what we are doing. But Shepherd Pratt made some convincing arguments to the senators and representatives, and they followed that approach, which I think we can live with, given some of the challenges with behavioral health. So, thank you very much. I guess we could conclude that Chairman Moffett absorbed about an hour and a half of your time because we're done in record time today.
Politically, may I make a politically incorrect statement because I can do it? Good to not have an Irishman in the chair who doesn't talk the whole afternoon and gets right down to business.
I don't think anybody has ever accused me of not talking before, but thank you. Hearing nothing else before the commission, I will accept the motion to adjourn. All in favor? Opposed? Till next month.